Well, one argument is that price rationing is simply unsustainable. We cannot do it. The reason for this is, as suggested before, our demands for healthcare are insatiable. We want more and more, and our demands for healthcare will constantly grow. And if demand is infinite and demand is constantly growing, then it stands to reason that the price of healthcare will continuously grow. And we all know this. Now you're all healthy folk. I know young people don't know, but the price of healthcare is rising really fast. For sick people like me, we know this. We fall out of bed every morning. We've got to fix that. So the price of healthcare then will grow, and this is going on then in the United States system. We see that the price of healthcare is constantly growing. That is a problem because in our system, increasingly fewer and fewer people are capable of paying that price. Now, this is partially we're talking about the question of the uninsured, but to make it quite clear, one of the things that is happening, a trend in the United States, is that there is a generalized decline in the access to private health insurance. So this is the percent of the 65 and under 65 population in the United States with access to private health insurance. And you can see that from 1987 to 2007, we've had this decline from about 76% to about 69% decline in access to private health insurance. And that's a trend that has been long going and appears to be escalating. One reason for the decline in access to health insurance is the fact that most Americans who have access to private health insurance have access to private health insurance through their employer. And one thing that has become clear over the last decade and 2 decades is that employers are increasingly less likely to provide health insurance as a benefit of employment. That is on the decline. Is on the decline even in the government is increasingly less inclined to provide health insurance to its citizens. And so employment-based health insurance is increasingly difficult to get. Your generation will find getting a job and getting health insurance really hard. Sorry. What that means then is that we are being priced out of the market. And this isn't simply a question of poor people being priced out of the market, but the pricing out of the market is becoming a generalized trend. So this is the percent of the group who is covered on this axis, and this is over time. And then the lines represent people at different levels of poverty. So this is below 100% of the poverty line. This is people from 100% to less than 150% of the poverty line. Right? 150 to 200, and 200 or more. So people live above twice the poverty line. And their access to private health insurance. And one of the things you can see is the steepest decline is occurring in this middle rung of people who are just above, these are kind of working class people who are just above the poverty line, but just below what we would call kind of strong middle class. And these people are seeing very stark declines in their access to health insurance. And that is directly the result of a decline in employer-based health insurance in this country. But even people who live above, well above the poverty line, the top green line, have seen a much less severe, but still have seen a decline in their access to private health insurance. And over time, this will continue. As we drive the cost of healthcare up, it will become increasingly difficult for us to sustain a private-based health insurance system. Fewer and fewer of us will be able to pay the price. The second kind of problem with price-based rationing involves issues of the distribution of care. This price-based rationing creates, in fact, a very inefficient healthcare system. Inefficiency meaning the amount we spend on healthcare and the amount of health output we get out of it is, in fact, quite inefficient in a price rationing system, which seems kind of strange because we expect that the market provides maximal efficiency, right? That's what everybody in your economics classes, and that's what they tell you. The market produces maximal efficiency. But in healthcare, this turns out not to be true. And the reason for that is because healthcare is being provided in the basis through the market, on the basis of who can afford, who can pay for it, which is quite, of course, distinct from who needs it. So that you have a problem. There's people who have the need and therefore do not have the means. And then you have the people who have the means but do not necessarily have the need. For a doctor who is trying to sell this service, this is a dilemma, right? Is that to maximize money, you want to, of course, find the people who are capable of paying the price, but those people may not have sufficient demand. Make sense? One of the interesting facts, two of the interesting facts about healthcare is that, first is that healthcare is affected by what we call supplier-induced demand. Right? It's a fancy kind of economist phrase. And what it means is this, is that when you go to the doctor, you don't know what you need from the doctor. Right? You go to the doctor and something's wrong with you, and you don't know what it is. Right? So you go to the doctor and you say, doctor, there's something wrong with me. You need to tell me what it is and then tell me what I'm supposed to do. Make sense? Now if you think about this, then what you're doing is you're going to the doctor and saying, doctor, I want to buy your services, but I'm not exactly sure what of your services I need. So could you please inform me of what services I need so that I can then pay you for them? If you think about it, that's quite strange, right? I mean, you don't do this in other places. Like, you don't go down to Publix, right? You don't go down to the grocery store and just kind of kick a cart in the door and say, hey, Publix, I need some food, but I don't know what it is, and I don't know, you just put food in the basket, right? And then you charge me, and I'll just take it home, right? Because you know what, Publix would be filling that basket with caviar, right? I mean, use lots of, well, I guess Publix would be filled with caviar, right? It's funny. But they'd just fill it with all steaks and all kinds of junk, right? Fill in that basket, and then you'd get home and you'd have all this junk, and you'd know this, right? You'd have a $400 bill every week. It's stupid, right? But that's the nature of healthcare. The problem we have with healthcare is that when we want it, we have to ask the supplier how much of it we need. This puts the supplier of healthcare in the position of being able to oversupply us. Give us more healthcare than we actually need. And that's not to say every doctor does it every time, but it is to say that every doctor has the incentive to do it every time. Right? I gotta think of a really good example. I mean, it happens all the time, but I think of a good example from my own life. I was in the doctor with my son, and he was in for a checkup, and he coughed. He was just a little cough while he was in for his checkup. And the doctor said, he coughed. And I said, yeah, he coughed. He said, and this is, I swear this is a quote from him. He said, I don't think he has strep, but we should check it. No one thinks he has strep. Like, where does this idea come from? We should check that. Yeah, I get why you think we should just do it. Why don't we go ahead and do that and I'll bill you for that? Sure, right? Let's do that. It doesn't make any sense, right? But here's the other problem with healthcare. I paid my doctor when I walked in the door. I paid him a copay because I had health insurance. So in point of fact, I'm not paying the doctor after I walked in the door. Whatever he does to my son is free. I paid the $25 to see him. Whatever he does to him is totally free to me. Which is to say, when he said, I don't think he has strep, but we should test him anyway, I thought, I could tell the doctor no, but I really don't care. Right? Because I'm not paying anyway. And so you have this problem, this kind of combination of those who have access to health insurance have what we call a moral hazard, which is to say they don't pay the cost of the health care that they're getting. So they're more than willing to play along with supplier-induced demand. Right? So when you go in for a headache and the doctor says, you know what you need is an MRI, you say, well, why not? That sounds like fun. We'll put me in a big tube, things will go around. Right? Let's do it. Right? Because you're not paying the cost anyway. So the problem with letting then the price determine the distribution of care is that doctors and patients have this incentive to overutilize healthcare for those who are capable of paying for it. And they have, of course, no incentive to provide healthcare for those who may be in need who can't pay for it. Right? So then you get this strange situation which we have in the American healthcare system, not just the American healthcare system, other health systems probably too, but much more so in the American healthcare system, of having some people who are massively oversupplied with healthcare and other people who